do you even go on to investigate it? So just the other thing to comment, that syphilis is probably completely inappropriate because it's clearly not congenital syphilis. It's not a case of congenital syphilis. She's got no other features of it. And then the other thing, she's not a tertiary syphilis because she's not in the right age group. So we often end up doing a lot of unnecessary investigations without any thought behind it, really. And I think in our setting, it's fine to scan her because we've got access to limited implants. But I think, if you were in the middle of Africa somewhere, the question is, I'm just throwing it out there, would you even scan this patient at all? So if you picked up a Mondini, how does that help her? Do you know what I mean?
Yeah. I think the only time, I'm sorry. Go ahead, Tasneem. I'm sorry.
Yeah, so it was just, a lot of these sort of investigations for sort of how do you work the patient, a patient up like this, unless it's going to lead to sort of, it's part of a syndrome where you could pick up other renal or cardiac abnormalities. That would make sense because there's management involved in that. But in a patient who's not dysmorphic, with hearing loss, and we see this often, and that's why I'm asking the question, in a patient who's not dysmorphic, clearly not dysmorphic, who's now sort of, in the teens, with no other features of a syndrome, do you scan the patient or not?
Yeah, it's a great question. I mean, obviously that you approach it from, depends on where you're sitting, right? Obviously here in the States, geez, people get scans like they're taking a drink of water, right? It's because they're so readily available. It doesn't make it right. Doesn't mean it changes anything. I think that in this situation, when we talk about Mondini, if you don't know that before, you're absolutely right. You look at, are they syndromic or not? Are there any other issues? So, the main two common things that you might be associated with Mondini, we talk about Pendred syndrome and we talk about broncho-otorenal syndromes, right? So those would be commonly noted with that. And you'd want to make sure that there wasn't anything else going on there. But I think in this circumstance, if you're questioning, the main reason to scan this child, I think, would be, if you saw that conductive loss and you weren't sure on your exam, is there a congenital cholesteatoma? If you don't feel like you could see behind the drum well, or it was questionable that there was maybe, the drum was thickened, or you're worried at all about that, that would be the main reason to scan, because of, do you want to make sure you don't miss some kind of middle ear process, that something else is going on. But if, the exam looks great and you can see through the drum and you clearly don't see any middle ear processes and, things like this, then I think you probably necessarily don't need to scan. I mean, especially like you said, someone who's, you have to think about the clinical picture. We see classically here where, some kids will be born, they'll pass newborn hearing screens here in the States and they do fine. And all of a sudden they have a progressive loss of hearing in their early teen years, or there's a noted trauma and all of a sudden they lose hearing, right? And so there's this idea, and Rasmus mentioned this, is that, is this a relationship? Is this being exacerbated by some trauma? I mean, it sounds like the mother has, been abusive to the child. I mean, you don't know that. I don't know that. I'm not saying that. But we do know documented, traumas in a setting of EVA can precipitate hearing loss. So it can actually make things worse. So it's kind of nice to know that if you're going to counsel patients, particularly if they're involved with high risk activities like sports that could involve traumas, if that makes sense. But you're right though, Tasneem, I think it's challenging because I don't know, unless there's another clinical indication, you may not glean much more from this.
And then just one other question, on her audiograms. Sorry, there's a lot of feedback from my side. She has very poor speech for her pure tone thresholds. Sorry, I'm looking at it from my phone, so and I've got.
I couldn't quite see the numbers there. I'm trying to. Is it?
Yeah.
Is it? What's her percentage there? Is it? Sorry, I have to get really close. It's like 60, 65, 55%.
Yeah, I mean, the second one is 55 and 60.
Yeah.
So, hang on. I need to enlarge this. What's on the right side? On a speech discrimination was.
It looks like it was on the 60 and 50.
Yeah. 60% plus 55, then 20, 60, 50, 55 at 50, then 90 at 60.
Right. So 90 hearing level, it's 65. Okay.
Oh, okay. All right. Okay. Sorry. Yeah. Okay.
And then the left is 60 at the same presentation level, 90, right? Yeah. Right.
Yeah. Okay. Cool. Thanks.
So word discrims are, yeah, they're pretty low.
Yeah.
Yeah. Yeah.
Sorry. Thanks, Erasmus.
Yeah. Is she currently wearing hearing aids, Erasmus? I couldn't remember if you, but obviously she's just being worked up now. So she hasn't had any kind of hearing rehab to this point, has she?
Okay, I'll briefly talk about fetal alcohol spectrum disorders. So it's a spectrum of disorders that ranges from true fetal alcohol syndrome, partial fetal alcohol syndrome, and some alcohol-related neurodevelopmental disorders and death defects. And these children generally have behavioral issues, have learning difficulties, and they perform poorly in school, but there are classical features that are talked about, especially in the head and neck area, with about patients with fetal alcohol spectrum disorders. So the dysmorphic features are the short palpebral fissure, smooth philtrum, thin upper lip, microtia, and the railroad trachea. And so this picture is showing the railroad trachea appearance in patients with fetal alcohol spectrum disorders. So there has been, I think there's been a study done in Australia. It's a meta-analysis which looked at, I think it looked at about 25 studies resulting in 843 children with fetal alcohol spectrum disorder. So they were looking at specifically ear abnormalities, and they noted that the functional ear abnormalities that were picked up in children with chronic otitis, with fetal alcohol issues, the chronic otitis media, was they are mostly associated with cleft palate, abnormal auditory filtering, and central auditory processing problems. There's an unspecified conductive hearing loss. Then on the structural issues, there were microtia, railroad trachea, and the misplaced ear. There were no characteristics in ear malformations that they managed to pick out, but they noted that some children presented with some sensory neural hearing loss, but it wasn't attributable. It wasn't attributable to any specific syndrome or disorder. And I tried to look it up, any inner ear malformation against fetal alcohol spectrum disorders. There is nothing in literature that I could find, more so towards the Pendrin gene and Mondini malformation. I didn't find any association. So having looked at all this, my thinking was, did the fetal alcohol, that the exposure to the alcohol also contributes to the hearing loss in this child? Was the alcohol itself, then the low birth weight, admission into neonatal wards, if they all known factors for hearing loss. Then in addition to that, this child also has features of Mondini malformation. So I was thinking, is it, are we dealing with double pathology, or is it predominantly Mondini malformation causing all these problems? But I think the child developed normal speech, so I would like to believe that it's more towards Mondini malformation, because there are cases in literature where patients with Mondini were implanted as late as 40 years.
Mm-hmm. Yeah, you said she's one of 5 children. Is that correct?
Yes.
And the other children are not noted to have hearing loss, and you presume mom has had the same behavioral. Is she the oldest child? Do you know, of the 5?
So the other 4 siblings, they are all normal in terms of their behavior and their performance in school and their hearing. The mother says it's all normal. It's only this last born child.
Yeah. It's interesting. So obviously she, usually here, fetal alcohol, we typically see them being, as you described, I don't see a lot of kids with post-fetal alcohol, but, they may have a bit more dysmorphic features typically than what you'd expect to see, or what you see here. And so it's interesting. I mean, I think for her, if she could be implanted, there's people that will demonstrate in Mondini that you can get a straight electrode in pretty far on these. They publish reports, like even 30 millimeter electrodes being inserted into Mondinis, usually because the basal turn is healthy, and you can get in pretty far without resistance, and they actually do well. I mean, like a third of those will leak. You'll get like a CSF, kind of like a gushing type syndrome, but it can be managed with plugging the the round window with tissue. You still get some leak, but you can manage that. So, I mean, she's not so dysmorphic where it's like common cavity where it's hard to implant, or which they still can be, but still could be implanted. I mean, it's obviously you want to fit her with hearing aids and follow her closely the best you can, obviously. Yeah. Ashneem, are you planning ever to look at some of your peds folks at all for implants? Are you initially just going to target adults at this point?
So Greg, we are targeting adults at this point, but obviously this girl, she is, because of her age, she would come to she is a chronic care patient, so she gets seen kind of as an adult. Yeah. My big issue with her would be that she's got a mother who's got a previous alcohol problem, if not a current one. And it will be a social kind of thing that we would have to exclude before we just go ahead and implant it. Even if she audiologically would be a good candidate, I'd have to make sure social circumstances are great, because there's no way we're going to implant a child with the parents are possibly drinking or have an alcohol problem. The maintenance and all of that is going to be an issue. They need to be brought to hospital. They need to come for rehab. So we would get a social worker to sort of assess that properly.
Right. And I think it's and you definitely obviously need to make sure mom knows that this child is not acting out. This is not a behavioral thing. This poor girl can't hear. I mean, she's she's got compromised hearing. So, please stop, punishing her, gosh dang, that's rough. Yeah. Yeah. That's a challenging situation. Yeah. But interesting though. So do you see are you seeing quite a few syndromic kids with inner ear malformations in the clinics?
I personally haven't seen many kids. I think I've seen either 1 or 2. The other one is I think the Waardenburg syndrome. I think they were transferred from Red Cross, but I think most of the children are being seen at Red Cross Children's Hospital with these syndromes. But I don't know then what will happen to them in terms of when they get to their adult age.
Yeah. Well, I think the key is, on these situations, obviously, is follow her with, if they can, with audiograms, see how she does, and then fitting her with hearing aids if you can, the best way possible. Is she? You mentioned in school how the teachers noticed it mostly, right?
Yes.
Yeah. Right. So preferential seating in class and hearing aids and these types of things. Yeah. Yeah. So yeah, that's interesting though, but good to review those scans, because you said radiology didn't really see an abnormality there. You said Erasmus?
No, they just wrote it's a normal CT scan of the brain and the temporal bone. So I actually had to
yeah. See, that it goes to show you gotta that's why always review your own films. I mean, I would say on a monthly basis, I pick up some things maybe that radiology didn't see, and then I'll call them and say, hey, what about this? And so I think it just reinforces just always looking at your own films really critically and spending time. Because you can see not just features that can be of clinical consequence, but you might pick up subtle anatomic anomaly, which is very fascinating, which just shows you, which could have surgical implication. For example, if you have like a bifid facial nerve in the descending segment or things like this, a little subtle nuance when you're thinking about, especially surgical patients, how it could impact your approach or what you might expect to see. So, and then I always go back too. It's always interesting. Sometimes in surgical cases, like say for a cochlear implant, there may have been a really prominent overhang on the round window niche or something like this. And I'll always go back to the film and try to look at that and say, wow, that, was that noted on the scan pre-op? Could we tell that? Or maybe during a stapedectomy, they've got really heaped up otosclerotic bone was that evident on the scan? So it's always interesting to then go back too, and then kind of retroactively correlate findings after surgical intervention. So kind of interesting process to do, but you learn so much by doing that. So I encourage you to do that.
Okay.
Yeah. It's great. Interesting case. So where did you guys leave it then in terms of the plan for her or the follow-up?
So she's coming back this coming week for another hearing assessment. I think for a third hearing assessment. Then they were saying if they are not happy, they will do an APR on the right side just to confirm the PTAs and speech audio.
Okay.
So,
yeah. Okay. Yeah. Interesting case.
Because they were saying they don't want to start to offer hearing aids now without ascertaining levels. They may over or under amplifying, it won't be beneficial to you. So they want to ascertain hearing levels first.
Mm-hmm. Yeah. And I think it's interesting is that, if you look at that audiogram there too, is, when you see air conduction greater than bone conduction, obviously that's a tip off. Something's on a ride there, right? When you mentioned that in the audiogram on the right there in one of the settings. Yeah. So if you go back to that. I think it was there a previous one?
Yes, the one that was done.
Oh, there you go. Yeah, there you go. The pure tone. Yeah, on the right hand side, the right ear on the right hand side. Yeah, I think you mentioned that.
Yeah.
Mm-hmm. Yeah, that's a kind of yeah. So, and then obviously you look at reliability. I mean, it's challenging.
Okay.
Mm-hmm.
So I prepared, I think, a talk on inner ear malformations. Hopefully, I'll have time to go through the malformations. So I think from 2002-2004 period, I think Senaroglu came up with new classification of inner ear malformations, where there are about 8 or 9 different malformations, sub-categories in those malformations. So the 3 on my left, they are complete labyrinthine aplasia, which is known as deformity, the rudimentary otocyst, and the cochlear aplasia. they are not candidates for cochlear implants, they are candidates for auditory brainstem implants. Then the common cavity cochlear hypoplasia, incomplete partition, they are candidates for cochlear implant. Then our patients with cochlear aperture abnormalities and cochlear nerve abnormalities, some they require cochlear implants, some require auditory brainstem implants, especially when there is no cochlear nerve to talk about.
Mm-hmm.
So the inner ear, the cochlear outer length is about 42 millimeters, and 53% of the top of that total length is made by the first 10. Then the second 10 makes up about 30% of the total length, and the remaining will be the apical 10. And generally, the height of the cochlea is between 3.3 to 4.8 millimeters. And surgically, the challenges in managing inner ear malformation is during surgery for cochlear implants, there is a risk of and there have been some children who were eventually diagnosed to have Mondini malformation from having presented with a risk or with a recurrent meningitis. About 30% of patients with inner ear malformation will have facial nerve anomalies, and the other challenge is also decision making for surgical approach, like auditory brainstem implant versus cochlear implants, and the type of electrodes that may be used, and also the timing of surgery. So these are some of the challenges in managing patients with inner ear malformation. So the CT scan views that so there's a mid-modular view on my left, then the inferior to mid-modular on my right. So on the mid-modular view, we are supposed to appreciate the cochlear aperture, the modulus. So the cochlear aperture and the modulus, and we are supposed to appreciate all the tails of the cochlea. Then just at the basal window cut, we're also supposed to see the interscalar sector of the middle and the apical chain. So these are normal CT scan views. Then on the MRI scan, you can clearly see the cochlear nerve going to the modulus, and then the cochlea with all its chains. And in high resolution MRI scan, you can clearly see the scalar tympani and scalar vestibule. Then on the sagittal cuts, you can see all the four nerves in the internal auditory meatus. I think it's important to note the diameters of these nerves, because in some inner ear abnormalities, there's just a combined cochlear vestibular nerve. So we want to convey its diameter to the facial nerve. So the first abnormality is the Michel deformity, which is the complete labyrinthine aplasia. So these patients are not amenable to CI surgery, they wander in ABI. And when you do a CT scan, there is no inner ear to talk about, from the middle ear straight to the middle fossa. Then the next is the rudimentary otocyst. Again, these are candidates for auditory brainstem implants, and it's usually characterized by a incomplete millimeter-sized representation of the otic capsule, and you won't be able to identify any internal auditory meatus. And normally the bony canal is also absent. Then the cochlear aplasia is characterized by the complete absence of the cochlea. So these are candidates again for auditory brainstem implant. The cochlear nerve canal and the cochlear nerve are usually absent. And when you do a CT scan, what you appreciate is a dense otic capsule and the absent cochlea absent cochlear nerve in the cochlear canal. Then the promontory, it's hypoplastic, which is typical when there is no cochlea. Promontory is hypoplastic. The vestibule and the semicircular canal, they are malformed and standard, and the facial nerve is anomalous. The middle ear may be normal sized with normal ossicles. Then the next cochlear abnormality, it's a common cavity where there is no differentiation between the cochlea and the vestibule. It's a one common cavity, and usually even on the nerves, it's one nerve, cochlear vestibular nerve. These patients may be implanted with custom-made electrodes, where you want the electrodes to sit on the entire circumference of the common cavity. I think there are different techniques of implanting in the common cavity. Some they make 2 holes, but I think now more and more people are just implanting through a single opening into the common cavity. Then there's cochlear hypoplasia. So in cochlear hypoplasia, the size of the cochlea is smaller than normal, and there are various internal abnormalities that are noted. So in cochlear hypoplasia, there are about 4 types, type 1 to type 4, and the cochlear nerve often is hypoplastic or absent, and the internal auditory canal may be normal or narrow most of the time. They have a normal vestibular aqueduct. So this constitutes about 15% of inner ear malformations. So in cochlear hypoplasia type 1, it's a bird-like cochlea, and it's an ovoid small cochlea with absent. So there's no modulus and no interscalar septa. Then in type 2, the cystic hypoplastic cochlear hypoplasia with a similar external shape to the normal cochlea, but it's slightly smaller with a defective modulus and interscalar septa. Then in type 3, the cochlea is less than 2 tenths. It's shorter, and the modulus again is shorter, and the length of the interscalar septum is reduced, as we see in these pictures. Then in type 4, so there's a hypoplastic middle in apical tents with a normal basal tail. So this is a type that I feel maybe for me personally, I may confuse it with incomplete partition type 2. Then the next abnormality is an incomplete partition of when the external condor of the cochlea is normal, and but the defects they involve the modulus and interscalar septa. So incomplete partition type 2. It may be isolated in type 2, or there may be a Mondini malformation. So for us to have a Mondini malformation, we need a triad of enlarged vestibular aqueduct, mildly dilated vestibule, and a cystic apex. And there is usually on the CT scan, there's an absent interscalar septum and an osseous spiral lamina with a deficient modulus. An incomplete partition type 3 is one that is X-linked stiffness. It affects male patients with predominantly sensory neural hearing loss. The interscalar septa are present, but the modulus is absent. I think I will show on the next picture. So this is a drawing of the different types of the cochlea from a normal cochlea, where the modulus and the tens, you can appreciate all the tens. Then in type 1, you can't appreciate any modulus. It's just a complete cyst. Then in type 2, the modulus is there, but it's small. We can see the basal term, but we can't differentiate in the apical and the median term. Then in type 3, you can see the interscalar septa, but there is no modulus to talk about. So on the CT scans, so this is a incomplete partition type 1, where it's just a cystic cochlear vestibular malformation with no modulus, no interscalar septum, and the vestibule it's dilated. Then incomplete type 2 on the CT scan, we can see the enlarged vestibular aqueducts, dilated vestibule, and fewer tails of the cochlea on the axial. Then on the coronal, again, you can see that it's a cystic middle in the apical term, and we can also appreciate the enlarged vestibular aqueducts to make it to be associated with the Mondini malformation. Then in type 3, which is the X-linked deafness for mostly male patients, we can appreciate the interscalar septa. So the interscalar septa is there, but we cannot appreciate the modulus. The modulus is absent. Then now we go to enlarged vestibular aqueduct, which is the most common inner ear malformation. These patients present fluctuating and progressive hearing loss, and there are associations with pendred, incomplete partition type 2, and these patients may have a gusher during the cochlear implant operation. So there are various criteria like what profile alluded to. So I captured that 2. There is the valvasory criterion, which measures the midpoint, and they said that if the diameter is more than 1.5 millimeters at the midpoint of the vestibular aqueduct, then it's an enlarged vestibular aqueduct. Then there is a newer criteria, which is the Cincinnati criterion, which says if the midpoint width is greater than 1 millimeter or the opercular width is greater than 2 millimeters, then we consider it as an enlarged vestibular aqueduct. Then now we have various forms of cochlear aperture abnormalities, where there is a cochlear hypoplasia, cochlear aplasia, and then now sometimes you may see a narrow internal auditory canal. So these patients present severe to profound hearing loss. And it's also important to note that these patients, especially children, the cochlea is normal. So during newborn hearing screening, they may pass with OAEs. So if you are suspecting cochlear aperture abnormalities, these are the children that will need an ABR because the OAEs may be present. If there's a cochlear hypoplasia, they benefit from hearing aids or a cochlear implant. If there is an aplasia, then these are candidates for an ABI. Then cochlear nerve abnormalities, say the hypoplastic or absent. So generally, the caliber of the cochlear vestibular nerve should be 1.5 to 2 times bigger than the ipsilateral facial nerve. So sometimes, especially in common cavity, you are trying to gauge if the cochlear vestibular nerve is normal or hypoplastic. We use this rough approximation. So there may be an absent nerve and may be hypoplastic. So if the nerve is hypoplastic, we may benefit from a cochlear implant or hearing aid trial. If there is no nerve, then these are candidates again for ABI. Then I think in the next 2 minutes, I'll just briefly talk about the Mondini malformation, where there is a triad of enlarged vestibular aqueduct and enlarged vestibule, then incomplete partition type 2. There is a progressive hearing loss, which may be sensory neural, which may be conductive, which may be mixed. the conductive component, like what Prof alluded to, it normally comes from the third window phenomenon of the enlarged vestibular aqueduct. And these children, they may present with recurrent meningitis. I put the role of hearing aids there because in all the literature that I've gone through, I haven't seen any where they were commenting about the effects or if the hearing aids are effective in children with a Mondini. Then there's a study that was done in China about cochlear implants in children with Mondini. So they noted that the auditory skills of the children developed similar to those with radiologically normal inner ears, because they noted that in Mondini generally the basal chain is normal. And the majority of the spiral ganglion cells, they reside in the basal chain. So this helps them to develop their auditory skills better. And I think there was one of the studies as well that checked on the number of the spiral ganglion cells. Normally in normal cochlea, we have about up to 30,000 spiral ganglion cells. But in children with Mondini, they may have up to 16,000, and most of those 16,000, they reside in the basal chain, So hence, they postulate that they contribute to the development of the auditory skills in children with Mondini. And cochlear implant was shown to be effective in Mondini. I think there are various studies now that have been done. There's always a risk of a gusher in children with Mondini, and also there are facial nerve abnormalities up to 30% of children with Mondini. Prof, I can see now it's 13:30, maybe I think I'll stop here. I still have a few slides to talk about the enlarged vestibular aqueduct and also what to do when you encounter a gusher during the operation.
Yeah, it looks good. Great job. Very, very good. Very comprehensive. Excellent.
Greg, can I just ask you?
Yeah.
With that 30% risk of a gusher,
Yeah.
I know you said most of them actually sort of stop intraoperatively. But when you do these, you wouldn't go and do a subtotal petrosectomy straight off with that risk? I mean, I suppose it's a bit different for you guys because with us, obviously, we've got donated implants, so it's not like we've got a lot to spare if the patient develops a leak, if you know what I mean, and that doesn't stop.
Yeah, I mean, honestly, it's been a long time since I've done one of these, because most of these are, we have our peds guys do most of these. But in the ones that I have done, we've been able to stop the leak. You kind of know what you expect, so you kind of have tissue ready. And I think a lot of it is the size of, your cochleostomy is not very large, obviously, and so if you can get the electrode in and then pack it, usually it does pretty well. Honestly, you can usually control that. Usually, like what Rasmus has mentioned here, like muscle or fascia. Oftentimes, I'm harvesting at the beginning of the case. I'm getting on all my implants, I usually take just as I'm opening up lifting periosteal flaps, I have a decent amount of periosteum that I take just for the packing. In a situation like this, I'd probably have something ready to, like a little baby temporalis muscle or something like that. Never really used any glues or anything like that. Never really had to do that. And I've never had to actually go and go deeper actually to control the leak. So, but my experience with this has been pretty limited. It'd be interesting to see what some of my peds folks who do this on a more regular basis, what they do, and how involved they've had to go down this, this decision tree where you've just mentioned. Have you done many of these, Tashneem?
We had one. Erasmus, what was the last CI where we were concerned? Was it enlarged? It was enlarged vestibular aqueduct bilaterally. Yes, Patricia, and
Yes.
she had a bit of I mean, it was a bit of an anticlimax. You know, I was kind of expecting a lot more gushing with that gusher. But I mean, very glad it stopped. And we used the form electrode with her, and
Yeah.
that was that. But I will say this: I've heard of 2 cases from colleagues who've done implants in children who've had gushes, and the one ended up with a lumbar drain
Okay.
post-operatively because the leak wouldn't stop, and
Ah,
the other one they had to go back and do a subtotal, which, you know, I think in a private patient, but even for a private patient, right, because they're still paying for it,
yeah.
it's so the question is always, and I think this is the difficult bit, is that especially with the cost of these things, it's not like it's a stapes piston. It costs a fortune, these things. And so I'm always worried that if there's a chance that it's not going to stop, is it not better to just, but everyone I've spoken to have always told me they would do it. Usually resolves. You put in the
Yeah.
electrode, you use a form, it stops, it's not. I'm always a bit concerned that there's going to be that one patient that
Of
doesn't
course.
stop. And
Yeah.
so my colleague it was a pediatric patient, and the person was leaking in the ward for I don't know how long. It was weeks,
Mm,
and eventually had lumbar drains. I mean, that's like a nightmare story.
it is. Yeah.
Yeah.
Yeah. I think you hope
It's,
it, yeah, I think that's more the exception than the rule. I don't think it happens to that degree. You know, again, like I said, I'd be interested in talking to some of my colleagues who do it on a more regular basis than I have over the years. I think never had to go that route that far down the line. But you know, I think it's a good thing to know if you're going to go and do a case like this to really make people aware of what can really happen so that it doesn't come out as a surprise, you know. Obviously not to frighten people, but you always have to be realistic as well. So when you're counseling these folks, you really have to tell them that that could be the outcome, you know, but less likely. Yeah. Are they doing, when you say your other colleagues, who was doing these? Was this a different institution, or was this,
yeah, it was Louis. You met Louis?
yeah. Okay.
Yeah.
Louis. Okay.
So
Got it.
he,
Okay.
he
Yep.
he had he had a case like
Yeah.
that, and I mean, it was
Yeah. That's,
and Louis is a good surgeon, so I
yeah.
don't think it
Yeah.
was. I think it was just one of those rare things, like
Yeah.
you say, that
Sure. Yeah. Yeah.
yeah. So
Hmm.
just so it was it, and then the other one was a case in Johannesburg where, but they were quite terrible cases because, you know, it's a very small community of
Hmm.
surgeons who do these CIs, so they present them at meetings, and obviously everybody who's doing CIs knows about it. It's like
Yeah.
so I think
Right.
those were the 2 extreme cases. Yeah. Just my
Yeah.
other comment about this fetal alcohol is, I mean, I don't think she necessarily, other than the Erasmus, sorry, I missed the first part of the presentation. So it's just the sound wasn't very good. Does she have a lot of signs of fetal alcohol? Sort of in terms of dysmorphic features.
So I didn't get you. Come again.
So did she have dysmorphic features of fetal alcohol syndrome?
Yes, she did. She had I think a smooth pupil, ears are low set, and also a short palpebral features.
Okay. I mean, I
Yeah.
think the other the usually, I mean, obviously it varies in severity, but sometimes there are also quite a few cognitive issues in children with fetal alcohol syndrome. And I'm not sure if that would be an issue with, not in her necessarily, but just something to bear in mind. And then on the papers that you had with hearing loss and fetal alcohol, at what level was that level of hearing loss? Was it thought to be central, or was it affecting the nerves, or?
It was predominantly the middle ear chronic otitis media. That was the commonest finding. But some children, they had sensory neural hearing loss. I think not specifically at birth, but along. I think they followed them up for about 5 years. So they had a mixture of both the conductive hearing loss and the sensory neural hearing loss.
Yeah. And did you get a sense of what she was like cognitively? I mean, how does she do at school academically? Is she quite sort of normal functioning, high functioning, or is she in a special school?
She's in a normal school, but I think she's not performing well at time, or she's read several times.
Yeah, it's quite interesting, Greg, because we see quite a lot of fetal alcohol in our community, mainly because they have, especially in farms, they have what they call the I don't know how to say this in English. I'm going to say South Afrikaans word, but they have that. Well, they used to have. I'm not sure if they still do the DOP system where they pay the farm workers with alcohol.
Oh, wow.
So yes, and so it's like a cheap form of labor, but at the same time, you kind of paid. Yeah, that's what used to happen. Obviously, now we see alcohol. So that was predominantly the main reason for a lot of the fetal alcohol. I'm sure that's regulated now. Probably doesn't happen to the same degree it used to in the past, but we still see a lot of fetal alcohol syndrome. And the common, our schools are not really good at picking up these kids that are struggling. And we have this type of school system where if a child doesn't perform, they still go on to the next grade. So a lot of these things are often missed. And so all of those cognitive sort of inattention, motor problems, it often gets missed. So we would have to look if she was, if she wasn't picked up at, if she wasn't picked up at the developmental clinic at Red Cross, if she wasn't a known patient there, then it's definitely something that we would have to have her formally assessed, properly, because a lot of those things often get missed completely.
Yeah. In this case, they get chalked up to maybe is it the child's behavioral issues? Well, and then gets disguised as that, which is it's too bad. That's hard.
Yeah.
Okay. About the history, so she was picked up as potentially dysmorphic at the baby clinic, and then appointment was made for the high risk clinic because the mom said that she obviously declared the fact that she drank quite heavily during especially the last part of her pregnancy, and so she just missed that follow-up. But when I examined her, she definitely met the criteria for fetal alcohol syndrome because she's got all three features. So she's got the short palpable fissure, the smooth philtrum, low set ears. She's got the behavioral issues and the learning disability. There's a clear history of drinking in pregnancy. So that's the criteria. And then obviously the last one is with regards to CNS abnormalities, which is why the scan also was requested. So she meets the criteria. I just don't think there was proper follow-up in regards to that.
Yeah.
Yeah, this is looking less and less like a
right. Be interesting to see what her siblings are like, over time, to see, because presumably, unless mom has changed her ways during the other pregnancies, you assume there could be some carryover into the other children as well, Yeah.
They live in Manenberg, which is quite a gangster-ridden, neighborhood. So mom said she didn't really pick up the schooling issues because most of the time over the last few years, she never went to school because of the shootings and stuff in Manenberg. So it was really the teachers that were like quite adamant that there's something wrong. She keeps behavioral issues. There's something clearly wrong. So it wasn't really the mom that initiated the referral. It was the teachers that initiated.
Okay. Well, it's good that at least they alerted somebody. That's good to know. Yeah, that's good. Yeah. Wow. Well, thank you guys. I have to get off to the hospital, but yeah, great job, Erasmus. Really interesting topic, obviously, very important. Yeah, so that's great. Good job with all that.
Thanks, Prof.
Thank you, Prof. Good day.
Yeah, you guys have a great weekend. Tashneem, are you I was hoping we could catch up on some stuff next week if you have some time next week. I don't know how your week looks. You're probably pretty busy, but
do you want to catch up before Friday?
Yeah, that'd be great if possible. Do
Yeah.
you mind just if you send just maybe over the weekend if you have some time, send me an email on some times that may work for you next week.
That's fine. I can do
And then we
that.
could
I
set
can
up
do
a
that.
Zoom to get caught up on a few things as we go forward. Does that sound
That's
good?
absolutely fine. 100%.
Yeah, great. Well, you
Cool.
guys take care. Enjoy your weekend. Hopefully, you get a little rest.
Yeah, thanks. You too. Enjoy your theater. Thanks, Erasmus.
Thanks, guys. Take care. Bye-bye.
Bye. Bye-bye.
And